Welcome, everyone, to today's lecture on health production functions. Our objective is to move beyond a simplistic understanding of health and explore through a rigorous economic lens. At its core, a health production function is a conceptual model that relates a set of inputs, like medical care, lifestyle choices, socio-economic factors, and the environment, to a single output, an individual's or a population's health status. This framework is crucial because it allows us to analyze the efficiency and effectiveness of our investments in health. It challenges the common assumption that more healthcare spending automatically leads to better health outcomes, urging us to consider the marginal returns of each input. In a world of finite resources, this is not just an academic exercise, it's a practical tool for guiding public policy and resource allocation. Our primary focus today will be on the application of this framework within the Canadian context. Canada's publicly funded, universal healthcare system, enshrined in the Canada Health Act, provides a unique and valuable case study. Unlike a multi-payer, largely private system such as the one in the United States, our system attempts to equalize one of the most significant inputs, access to medical care. This allows us to more clearly isolate and examine the contributions of other factors, such as socio-economic status, education, and lifestyle, which often play a more profound role in determining health. We will use this lens to understand why, despite having a universal healthcare system, persistent health inequities remain, particularly among indigenous populations, rural communities, and low-income groups. Over the course of this lecture, we will explore the various components of the health production function in detail. We'll begin with the challenge of measuring health, moving beyond simple metrics like mortality rates to more nuanced indicators of morbidity and well-being. From there, we will unpack the key determinants of health, dedicating a substantial portion of our discussion to the powerful, often overlooked influence of social and economic factors. We will also touch on the role of technological innovation, the challenges of an aging population, and the growing importance of mental health as a determinant. Finally, we will consider the implications of this framework for future health policy in Canada, arguing for a more integrated, intersectoral approach that recognizes the powerful link between social policy and health outcomes. This lecture is intended for a graduate-level audience in economics or public health, assuming a foundational understanding of economic principles. Our goal is to equip you with a conceptual toolkit to critically evaluate health policy and contribute to a more equitable and efficient health system. As we delve deeper into the health production function, our first challenge is one of measurement. How do we quantify a concept as complex and multifaceted as health? Economists and public health researchers have developed a suite of metrics that generally fall into two categories: mortality and morbidity. Mortality measures, which relate to death, are the most objective and historically reliable. The crude death rate is a basic metric, but it can be misleading because it doesn't account for the age structure of a population. A more sophisticated measure is life expectancy at birth, a powerful summary statistic that reflects the average lifespan of a newborn given current mortality trends. This metric is a hallmark of national success, and Canada consistently ranks among the top countries globally. However, even life expectancy can mask significant internal disparities. The infant mortality rate, IMR, and under 5 mortality rate, U5MR, are particularly sensitive indicators of a nation's development and a sign of a well-functioning public health and social safety net. A low IMR speaks volumes about a country's access to prenatal care, sanitation, and nutrition, but relying solely on mortality data provides an incomplete picture. It tells us nothing about the quality of life or the burden of disease. A person may survive a chronic illness for decades, but if they are living with significant pain or disability, this is a health burden that mortality measures cannot capture. This is where morbidity measures become essential. Morbidity refers to the presence of disease or illness. Its measurement is inherently more challenging because it often relies on subjective data. Self-reported health status, SRHS, is a simple yet remarkably predictive metric, often captured in large-scale surveys where individuals rate their own health. Despite its subjectivity, SRHS has been shown to be a strong predictor of future healthcare utilization and mortality. Other morbidity measures include the prevalence of chronic diseases, which provides a snapshot of the burden of conditions like diabetes, heart disease, and mental health disorders. The most sophisticated, though controversial, measure is the disability-adjusted life year, DALY. A DALY attempts to combine mortality and morbidity into a single metric, representing a year of healthy life lost due to premature death or a period lived with disability. While the DALY provides a powerful tool for global health comparisons and prioritizing interventions, assigning a disability weight to different conditions can be ethically fraught. Taken together, a combination of mortality and morbidity measures provides a more comprehensive and actionable picture of a population's health. The choice of metric depends on the research question, but a robust analysis requires us to look at both the quantity and quality of life. Once we move beyond medical care, the most powerful and consistent determinant of health is a person's socio-economic status, SES. In Canada, where access to medical care is universally ensured, the social gradient in health is particularly stark. The evidence for this is overwhelming. A person's health outcomes are directly correlated with their income, education level, and occupation. This is not a simple binary of rich versus poor. It is a continuous gradient where each incremental step up the socio-economic ladder corresponds to an improvement in health. The mechanisms behind this gradient are complex and multifaceted. Income provides the resources to purchase health-promoting goods and services, such as nutritious food, safe housing, and opportunities for physical activity. Conversely, poverty is a condition that produces chronic stress, which has direct physiological consequences on the body, including increased inflammation and weakened immune function. Chronic financial insecurity is a potent stressor that erodes both mental and physical health. Education is another critical component of SES. Higher levels of education are strongly linked to better health outcomes, and this relationship is causal. Education provides individuals with health literacy, empowering them to make informed decisions about their lifestyle, and to effectively navigate the complex healthcare system. More educated individuals are also more likely to be employed in stable, well-paying jobs with better benefits, which in turn provides a powerful buffer against health risks. Employment status and working conditions also play a vital role. A stable, well-paying job with a supportive work environment is a source of purpose and social status, and it provides health-promoting opportunities. Conversely, precarious, low-wage work often involves physical strain, stress, and a lack of control, all of which are detrimental to health. The social gradient is a persistent and troubling feature of our society, and it underscores the fact that a narrow focus on medical care is insufficient for achieving health equity. Any effective health policy must recognize and actively address the underlying social and economic conditions that shape a person's health trajectory. In essence, social policy is a form of health policy. The relationship between education and health is one of the most studied in health economics, precisely because it highlights the challenge of establishing causality. On the one hand, a simple correlation is undeniable: more educated people are, on average, healthier. But does education actually cause better health? This is the central debate. Theory 1 posits a direct causal link. Education can improve health by making individuals more efficient producers of their own health. More educated people may be better at processing complex information, making them more likely to read and understand health warnings, follow a doctor's advice, and adopt healthier lifestyle habits. Education also often leads to higher income, which provides the resources to purchase health-promoting goods and services. A higher income also increases the opportunity cost of being sick, giving individuals a greater incentive to invest in their health. Theory 2 challenges this by suggesting that the correlation is spurious and that the relationship is driven by an unobserved, third factor. This is known as omitted variable bias. For example, an individual's intrinsic patience, ability, or family background could influence both their educational attainment and their health outcomes, confounding the relationship. To overcome this challenge, economists use sophisticated techniques, and the natural experiment is one of the most powerful. A classic example is the landmark study by Arist-Monet, 2002. She exploited the staggered implementation of compulsory schooling laws across U.S. states. These laws required children to stay in school longer, effectively providing an exogenous shock to a person's educational attainment. Since the timing of the law was unrelated to a person's health, she could use it as an instrumental variable to isolate the causal effect of education. Her findings were striking. Each additional year of compulsory schooling led to a significant increase in life expectancy in later life. This study provides strong evidence that education is not just correlated with health, but is a powerful causal determinant. It is a critical finding for health policy, as it suggests that investments in education are also a long-term investment in public health. A person's health is not solely a function of their individual choices or socio-economic status. It is profoundly shaped by the physical and social environments in which they live, work, and play. The physical environment encompasses everything from the air we breathe and the water we drink to the safety of our homes and the presence of green spaces. For example, living in an area with high levels of air pollution is a direct risk factor for respiratory and cardiovascular diseases. Urban planning also plays a crucial role. A community designed for walking, cycling, and public transit, with access to parks and recreational facilities, promotes physical activity and reduces stress, leading to a healthier population. Conversely, a car-dependent suburban environment can lead to sedentary lifestyles and social isolation. The social environment is equally important. It includes the strength of our social networks, the level of community cohesion, and the presence of social support. Strong social ties act as a powerful buffer against stress and loneliness, which have been shown to be as detrimental to health as smoking. Policies that foster community cohesion, such as investing in public libraries, community centers, and shared green spaces, can have a profound positive effect on population health. The dynamic interplay between our genes and our environment is a fascinating area of research known as epigenetics. This field has demonstrated that a person's environment and lifestyle choices can alter their gene expression without changing the underlying DNA sequence. A person may have a genetic predisposition for a certain condition, but if they live in a low-stress, healthy environment, that gene may never be expressed. This provides a powerful biological link between the social and environmental determinants of health and our biological inputs. From a policy perspective, this is a profound insight. It means that while we cannot change a person's genes, we can change the environment in which those genes operate. This reinforces the importance of investing in social and environmental policies that create the conditions for all Canadians to live healthy lives, regardless of their genetic predisposition. In this way, public policy can directly shape the context for health. While a person's socio-economic status and environment are powerful determinants, individual lifestyle and behavioral choices are also critical inputs into the health production function. These choices, however, are not made in a vacuum. They are profoundly influenced by the very social and environmental factors we have already discussed. Let's first consider diet and nutrition. The link between a healthy diet and the prevention of chronic diseases like diabetes and cardiovascular disease is undeniable. Yet, the ability to choose and consume a healthy diet is not evenly distributed across the population. Food insecurity, the state of being without reliable access to a sufficient quantity of affordable, nutritious food, is a significant issue for many Canadians, particularly those in low-income households and remote northern communities. The concept of a food desert, an area with limited access to affordable and nutritious food, highlights a structural barrier that makes healthy eating difficult regardless of an individual's personal motivation. A purely individualistic approach to nutrition, therefore, ignores these systemic constraints. Next, we have physical activity. In an increasingly sedentary world, the health benefits of regular exercise, from managing weight to improving mental health, are well established. But again, access to safe, affordable opportunities for physical activity is a matter of equity. A person in a low-income neighborhood may not have access to affordable gyms or safe public parks for jogging, while a person in a high-income neighborhood may have these options readily available. Finally, choices about substance use, such as tobacco and alcohol, are also deeply rooted in socio-economic factors. People with lower levels of education and income are more likely to smoke, often as a coping mechanism for the stress of poverty. This creates a vicious cycle where poor health behaviors are both a consequence and a cause of social and economic disadvantage. Therefore, While health promotion campaigns are valuable, they must be part of a larger, intersectoral strategy that addresses the upstream social and environmental factors that shape these choices. A purely individualistic approach to health is insufficient and often perpetuates victim blaming, ignoring the systemic barriers that make healthy choices difficult or impossible for many Canadians. The most effective policy is one that makes the healthy choice the easy choice. Canada's universal healthcare system, enshrined in the Canada Health Act of 1984, is perhaps the most significant policy lever in the Canadian health production function. It is a system founded on 5 core principles: public administration, comprehensiveness, universality, portability, and accessibility. The primary goal is to ensure that all Canadians have access to medically necessary hospital and physician services, regardless of their ability to pay. From an economic perspective, this policy is a massive intervention in the healthcare input of the health production function. By removing the financial barrier to accessing care, the system aims to equalize this one variable across the entire population, thereby reducing the gradient in health that might otherwise be caused by a person's income or wealth. In a theoretical model, this would mean that differences in health outcomes would be more attributable to the other inputs, like socioeconomic status, education, and lifestyle, which are not universally provided. This allows us to more clearly study and understand the profound impact of those other determinants. The system ensures that preventive care, diagnostics, and treatments are available to all, leading to a healthier population overall. However, while our system is a source of national pride, it is not a panacea for all health issues. The Canada Health Act does not cover many crucial health services, including prescription drugs, dental care, eye care, and mental health therapy provided outside of a hospital setting. These gaps in coverage often fall disproportionately on lower-income Canadians, creating new financial barriers and perpetuating health inequities. For example, a person with a low-wage job may be unable to afford a necessary medication, leading to a worsening of a chronic condition. The existence of these gaps demonstrates that even with a universal healthcare system, health is still a product of a much broader set of determinants. The system ensures everyone has a baseline level of access, but it does not address the underlying social and economic factors that drive health disparities. This reality forces us to look at policy solutions that go beyond the traditional boundaries of the healthcare sector. The Canadian experience demonstrates that a universal healthcare system is a powerful start, but it is not the final solution for achieving true health equity. Building on the health production function, a growing number of policymakers in Canada recognize that social policy is, in essence, a form of health policy. From an economic standpoint, interventions that address the social determinants of health can have a much higher return on investment for public health than an equivalent investment in medical care, particularly when we are talking about marginal gains in a high-income country. Let's take income policy as an example. Recent evidence suggests that providing stable income support can dramatically improve health outcomes. The Canadian Emergency Response Benefit, served during the COVID-19 pandemic, was not designed as a health policy, but its impact on health was profound, as it reduced stress and food insecurity for millions of Canadians. Similarly, pilot projects on universal basic income have shown promising results in improving mental and physical health. The reasoning is simple. A person who is not constantly worried about meeting their basic needs has the mental and financial capacity to focus on their health. Housing policy is another powerful example. Access to safe, affordable, and stable housing is fundamental to health. Poor housing is a source of mold, pests, and exposure to environmental toxins, all of which contribute to chronic diseases like asthma. A person experiencing homelessness, conversely, faces extreme health risks, including higher rates of infectious disease, mental illness, and substance use. Investing in affordable housing and homelessness prevention is, therefore, a direct and cost-effective investment in public health. Finally, early childhood development and education policy are among the most impactful long-term health investments. A child who has access to high-quality early learning and a strong educational foundation is more likely to have a healthier, more stable life trajectory, which in turn leads to better health outcomes in adulthood. This intersectoral approach, which views the Department of Finance and the Department of Education as partners in public health, is a hallmark of a modern and sophisticated understanding of the health production function. It is a recognition that to improve health, we must build a more equitable society. A central message of the health production function is the critical importance of public health and prevention. The traditional, disease-centric model of healthcare is often a reactive one, where we wait for a person to get sick and then try to cure them. A more sophisticated approach, informed by the health production function, recognizes the immense value of prevention. From an economic perspective, the return on investment for a preventive public health intervention can be astronomical. $1 invested in a smoking cessation program or a public health campaign about healthy eating can save thousands of dollars in future healthcare costs related to treating smoking and obesity-related illnesses. The challenge is that the benefits of prevention are often invisible. We don't see the diseases that were prevented, so it can be difficult to justify public spending on these initiatives compared to visible, tangible investment like a new hospital. Nonetheless, public health interventions have been responsible for some of the greatest gains in life expectancy in human history. The eradication of smallpox, the development of vaccines, and the implementation of sanitation systems are all hallmarks of effective public health. In Canada, we see modern examples of this in our successful immunization campaigns, our public health education initiatives, and our policies on food safety and sanitation. A shift from a focus on individual treatment to population-level prevention is essential for the long-term sustainability of our health system. Public health interventions, unlike a new drug or a new procedure, address the root causes of disease for an entire population, often at a fraction of the cost. This lens forces us to think beyond the individual and to focus on systemic, upstream solutions that address the determinants of health. It requires a fundamental shift in our thinking, from a focus on treating illness to a focus on fostering wellness. This is particularly important for an aging population, where chronic diseases are a major burden. Investing in prevention is the most effective strategy for ensuring a healthier and more productive future for all Canadians. The principles of the health production function are not confined to developed nations like Canada. They are profoundly relevant in the context of global health and development. In many low and middle-income countries, the most significant health inputs are often not advanced medical technologies, but rather basic infrastructure and public health interventions. Health is a key indicator of development, as nations with healthier populations tend to have higher economic productivity and greater social stability. The relationship is cyclical. Better health enables economic growth, which in turn allows for further investment in health. Conversely, the high burden of preventable diseases, such as malaria and tuberculosis, acts as a powerful brake on economic progress. This is where foreign aid and international cooperation play a crucial role. Aid can be a significant input into the health production function, funding essential interventions like vaccination campaigns, clean water projects, and maternal health programs. A particular area of focus in global health is maternal and child health. The health of mothers and their children is a core indicator of a society's well-being and a powerful predictor of future health outcomes. Interventions that reduce infant and maternal mortality, such as skilled birth attendants and basic prenatal care, have a massive return on investment. The disease burden in low-income countries is heavily skewed towards infectious diseases and conditions related to malnutrition and poor sanitation. These are often diseases of poverty, and they are preventable. The health production function provides a powerful framework for understanding this. It tells us that to improve health in these contexts, we must not only provide medical care but also address the underlying inputs of poverty, lack of education, and poor sanitation. This requires a coordinated effort between governments, NGOs, and international organizations to invest in a broad range of inputs, from a child's early education to communities' access to clean water. Technology is an increasingly significant input into the health production function, fundamentally altering how we produce and consume health. The digital health revolution encompasses everything from electronic health records and telemedicine to mobile health apps and wearable devices. These technologies hold immense promise for improving health outcomes. For example, telemedicine can dramatically increase access to care for people in rural and remote areas of Canada, a persistent challenge for our healthcare system. Wearable devices and health apps can empower individuals to monitor their own health, providing real-time data on everything from heart rate to sleep patterns. This data can be used to promote healthier habits and prevent chronic diseases. This leads us to precision medicine, a field that aims to tailor medical treatment to an individual's genetic makeup. By leveraging big data and advanced analytics, doctors can predict a person's risk for certain diseases and prescribe treatments that are far more effective and have fewer side effects. This represents a move away from a one-size-fits-all approach to medicine. However, the rapid advancement of health technology is not without its challenges. The digital divide is a significant equity issue. People without reliable access to the internet, smartphones, or digital literacy skills are at risk of being left behind. This can exacerbate existing health inequalities, as those who are already socially and economically disadvantaged may be unable to access the benefits of digital health. The widespread use of health data also raises profound ethical implications. Issues of privacy, data security, and consent are paramount. Who owns this data? How is it used? And who benefits from it? There is a real risk that health data could be used for discriminatory purposes, such as denying insurance coverage based on a genetic predisposition. Therefore, as we embrace technology as a powerful input into the health production function, we must do so with a strong ethical framework that ensures its benefits are shared equitably and that individual rights are protected. Technology is a tool, and its impact depends on how we choose to use it. The health production function has traditionally focused on environmental and behavioral inputs, but a person's genetics is also a fundamental input. Our genetic code provides the blueprint for our biological makeup, and it can predispose us to certain diseases, such as cancer or heart disease. For decades, the debate over health was framed as a simple dichotomy: nature versus nurture. Are we products of our genes or our environment? The modern answer, informed by the emerging field of epigenetics, is that this is a false choice. Epigenetics studies how our environment and lifestyle choices can affect the way our genes are expressed. It does not change our underlying DNA sequence, but it can turn genes on or off. This is a profound concept. For example, a person may have a genetic predisposition for a certain condition, but if they live in a low-stress, healthy environment, that gene may never be expressed. Conversely, a person with a low-risk genetic profile can develop a disease if they are exposed to chronic stress, poor nutrition, or environmental toxins. This provides a scientific basis for the malleability of health and the importance of environmental inputs. It demonstrates that our genes are not a fixed destiny. They are highly responsive to the world around us. This has significant policy implications. It reinforces the argument that investments in social and environmental determinants of health are not just about improving quality of life, they are biological health interventions. A policy that provides affordable housing or nutritious food is, in effect, a policy that can positively alter gene expression for an entire population. This offers a powerful new way of framing our health debates. Rather than viewing health as a product of genetic luck, we can see it as a product of our choices as a society. We can choose to create environments that turn on the genes that promote health and turn off the ones that lead to disease. It is a powerful argument for a more holistic and intersectoral approach to public health. In recent years, the importance of mental health as a core determinant of a person's overall health has become increasingly recognized. The health production function must therefore account for psychological well-being as both an input and an output. Mental illness, which includes a wide range of conditions from anxiety and depression to more severe disorders, is a growing public health issue in Canada. The stigma surrounding mental health is a significant barrier to care. Many people are reluctant to seek help due to fear of judgment or discrimination, leading to a delay in diagnosis and treatment. This delay can have profound consequences, as untreated mental health issues can lead to social isolation, substance use, and a worsening of physical health conditions. The economic burden of mental illness is staggering. It leads to lost productivity, increased healthcare costs, and a significant reduction in a person's quality of life. The Mental Health Commission of Canada estimates that mental health problems cost the Canadian economy over $50 billion per year. Our current healthcare system, which is largely focused on physical health, is not well equipped to handle this growing burden. There are significant gaps in coverage, with services like psychotherapy often not covered by provincial health insurance plans. This creates a financial barrier that disproportionately affects low-income Canadians. To address this, we need to move towards integrated care models that treat mental and physical health as two sides of the same coin. This would involve embedding mental health professionals, such as social workers and psychologists, into primary care clinics. It would also require a greater investment in public health campaigns to reduce stigma and promote mental health literacy. This holistic approach recognizes that you cannot treat a person's physical ailments without also addressing their mental well-being. It is a critical next step in our evolution as a health system and a necessary addition to our understanding of the health production function. Canada, like many other high-income countries, is experiencing a significant demographic shift. Our population is getting older. The number of Canadians over the age of 65 is growing faster than any other age group, and this has profound implications for our health production function. The most obvious challenge is the increased demand for healthcare. As people age, they are more likely to develop chronic diseases, require more frequent medical visits, and need long-term care services. This will put significant strain on our healthcare system, which is already struggling with wait times and resource limitations. The burden of chronic disease is particularly acute. Conditions like diabetes, arthritis, and dementia are not only costly to treat but also significantly reduce a person's quality of life. The traditional model of acute, reactive care is ill-suited to manage these long-term conditions. However, the aging population also presents an opportunity. The health production function gives us a framework for thinking about healthy aging as a policy goal. Rather than just focusing on treating the diseases of old age, we can invest in interventions that promote wellness and independence in later life. This could include policies that encourage physical activity and social engagement for seniors, public health campaigns about fall prevention, and investments in home care to allow people to age in place. The goal is to maximize the number of healthy years a person lives, not just to extend their lifespan. This would not only improve the lives of seniors but would also reduce the overall cost to the healthcare system. The most effective policy for an aging population is one that empowers seniors to be active and engaged members of society, thereby reducing their reliance on costly medical services. This requires a shift in thinking, from viewing seniors as a burden on the system to viewing them as a valuable resource to be supported. The healthcare system itself is, of course, a critical input into the health production function, but it is not a monolithic input. Its efficiency and quality can vary widely, and this has a direct impact on health outcomes. In Canada, one of the most persistent issues is wait times for care. While universal access to medically necessary services is a core principle, a long wait for a diagnostic test or a specialist consultation can lead to a worsening of a person's condition, thereby reducing the health output of our system. The organization and structure of our system also matter. For instance, a strong primary care system, where people have a family doctor who they see regularly, is a proven way to improve health outcomes and reduce costs. A good primary care physician can manage chronic conditions, provide preventive care, and coordinate a person's care across different specialists. In this way, a strong primary care system is a highly efficient input. Conversely, a system that is overly reliant on hospital care is often inefficient and costly. While hospitals are essential for emergency care and complex procedures, many conditions can be managed more effectively and affordably in the community. Shifting the focus from acute hospital care to community-based care is a key policy goal in Canada. This would involve investing in home care, long-term care facilities, and community health centers. It would also require a greater emphasis on prevention and health promotion. By redesigning our system to be more efficient and patient-centered, we can get a much higher health output from the same level of spending. This is a powerful economic argument for healthcare reform. It is not about cutting costs for the sake of it, but about making smart investments that maximize the health output for all Canadians. From a macroeconomic perspective, health is not just a personal good, it is a form of human capital. The concept of human capital refers to the skills, knowledge, and health that an individual possesses. Just like an investment in a factory or a piece of equipment, an investment in a person's health can yield a significant return in the form of increased labor productivity. A healthier workforce is a more productive workforce. Healthy workers are less likely to be absent due to illness, and they are more likely to be engaged and productive while on the job. The economic cost of chronic diseases, such as lost wages and reduced productivity, is enormous. Therefore, policies that improve public health are not only a social good but also a smart economic investment. The link between health and education is particularly strong. A healthy child is more likely to attend school regularly, to be able to focus, and to perform well academically. A person with a chronic health condition, conversely, may struggle to complete their education. This creates a vicious cycle where poor health leads to lower educational attainment, which in turn leads to lower income and poorer health later in life. This also relates to the intergenerational transmission of health. The health of parents can have a profound impact on the health and development of their children, even before they are born. A mother's health and nutrition during pregnancy, for example, can affect a child's long-term health trajectory. This means that health inequities are often passed down from one generation to the next. The health production function provides a powerful framework for understanding this cycle and for designing policies to break it. By investing in the health of pregnant mothers and young children, we are making a long-term investment in the human capital of an entire generation. This is a critical insight for policymakers. It tells us that to build a more prosperous and equitable society, we must start by building a healthier one. In a world of finite resources, policymakers face difficult decisions about how to allocate health spending. This is where economic evaluation, particularly cost-benefit analysis, becomes an essential tool. The goal is to ensure that we get the highest possible health output from our investments. Cost-effectiveness analysis compares the cost of an intervention to the health outcomes it produces, measured in a common unit, such as life years gained or days averted. This allows us to compare different interventions and choose the ones that provide the most bang for the buck. For example, we could compare the cost-effectiveness of a new drug for a rare disease to a public health campaign about smoking cessation. The public health campaign, while less glamorous, may be a far more cost-effective way to improve population health. Cost-benefit analysis takes this a step further by assigning a monetary value to the health outcomes. This is, of course, a highly controversial practice. It requires us to put a dollar value on a life, which can be ethically fraught. The methods used to do this, such as the value of a statistical life, are complex and subject to intense debate. But in a world where we must choose between competing priorities, this type of analysis is unavoidable. The ethical considerations are paramount. Does an intervention that is highly cost-effective for the general population but does nothing to reduce health inequities justify our investment? The answer is often no. An ethical framework for health policy must not only consider efficiency but also equity. The goal is not just to maximize the total amount of health in a population, but to reduce disparities and ensure that the most vulnerable are not left behind. This is a challenging balancing act for policymakers. Economic evaluation is a powerful tool for making rational decisions, but it must be used with a strong ethical framework that prioritizes equity and human dignity. The health production function provides a powerful lens for understanding the deep connection between inequality and health. In societies with greater income inequality, there are often wider disparities in health outcomes. The reasons for this are complex and multifaceted. The health of the wealthy continues to improve, while the health of the poor can stagnate or even decline. This is due to concentration of disadvantage, where multiple risk factors for poor health, such as low income, low education, poor housing, and social isolation, are concentrated in the same populations. It is not just one of these factors, but their cumulative effect that creates profound and persistent health inequities. We must also consider the intersection of health with other social divisions, such as race, gender, and geography. In Canada, for example, Indigenous peoples face a disproportionate burden of disease and have significantly lower life expectancies than the non-Indigenous population. These health inequities are not a result of lifestyle choices. They are a direct consequence of a history of colonization and ongoing systemic discrimination. To address these inequities, We need policy solutions that go beyond the healthcare system. The most effective policies are those that address the root causes of inequality. These could include progressive taxation, investments in affordable housing, and targeted programs that address the unique needs of marginalized communities. The goal is to not only provide a safety net, but to create a society where everyone has a fair shot at a healthy life. The health production function tells us that to improve the health of the most vulnerable, we must first address the social and economic conditions that produce disadvantage. This is a difficult and politically complex task, but it is a necessary one for building a more just and equitable society. It is a reminder that health is not just a personal matter, it is a political one. No discussion of health inequities in Canada would be complete without a dedicated focus on Indigenous health. The health disparities faced by First Nations, Inuit, and Métis peoples are not a matter of a simple health gradient. They are a direct result of a history of colonization and ongoing systemic inequities. The residential school system, the forced relocation of communities, and the loss of land and culture have all had profound and lasting effects on Indigenous health. From a health production function perspective, these historical factors have created a deeply unequal set of inputs. The social determinants of Indigenous health are particularly acute. Indigenous peoples face higher rates of poverty, food insecurity, and substandard housing. These are not minor issues, they are powerful drivers of disease. As a result, Indigenous peoples in Canada face a higher burden of chronic and infectious diseases, including diabetes, tuberculosis, and HIV/AIDS, and have significantly lower life expectancies than a non-Indigenous population. The current healthcare system has often failed to adequately address these needs. It has historically been a system that is culturally insensitive and has been a source of harm. The path forward must be one of reconciliation and systemic change. This involves moving towards Indigenous-led health governance, where Indigenous communities are empowered to design and deliver their own health services based on their own cultural values and needs. It also requires a massive investment in the social determinants of Indigenous health, including investments in clean water, education, and housing. This is a matter of both justice and public health. To improve Indigenous health, we must not only address the physical ailments, but also the social and historical wounds that are the root cause of these health disparities. The health production function provides a powerful economic and ethical argument for this approach. The health production function provides a framework for understanding the determinants of health, and it also helps us identify the policy levers we can pull to improve health outcomes. These levers generally fall into three categories: fiscal, regulatory, and informational. Fiscal policy uses the power of the purse to influence behavior. This can include taxes on unhealthy goods, such as tobacco and sugar-sweetened beverages, or subsidies for health-promoting goods, such as fruits and vegetables. The goal is to make healthy choices more affordable and unhealthy choices more expensive. A notable example is the high tax on tobacco products in Canada, which has been a powerful tool for reducing smoking rates. Regulatory policy involves using laws and standards to shape behavior and create healthier environments. This can include laws that require mandatory seatbelt use, regulations on air and water pollution, or mandatory food safety standards. These policies work by making the healthy choice the only choice, or at least the easiest one. Finally, informational policy uses public health campaigns and education to influence behavior. This can include campaigns about the importance of hand washing, the benefits of exercise, or the risks of substance use. While this is often the most visible form of public health policy, it can be the least effective if it is not supported by fiscal and regulatory policies. A public health campaign about healthy eating will have a limited effect if healthy food is unaffordable or unavailable. The key is to use a combination of these policy tools. The choice of which tool to use depends on the specific health issue and the context. For some issues, like air pollution, a regulatory approach is most effective. For others, like smoking, a combination of fiscal and informational policies has proven to be successful. The health production function gives us the economic and social rationale for using these levers to improve population health. Health is not just an economic or social issue. It is a profoundly political one. The decisions about how to allocate health spending, which policies to implement, and who benefits from them are all products of a complex political economy of health. Various interests and lobbying groups, including pharmaceutical companies, physician associations, and patient advocacy groups, all compete to influence health policy. The government, in turn, must balance these competing interests while also trying to serve the public good. The health production function, with its emphasis on the social determinants of health, challenges the traditional focus of health policy on the healthcare sector. This can create political friction. For example, a policy that addresses food insecurity might be seen as a social policy, not a health policy, and it might be resisted by political interests that benefit from the status quo. The reality is that health is often a political commodity. Decisions about health spending are made in a political arena, where short-term political gains can sometimes trump long-term public health benefits. A government might be more inclined to build a new, highly visible hospital than to invest in an invisible but highly effective public health campaign. This is a significant challenge to a holistic approach to health. The health production function, however, provides a powerful intellectual tool for advocacy. It allows public health advocates and economists to make a strong, data-driven argument that a dollar spent on social and environmental policies can have a much higher return on investment for public health than a dollar spent on medical care. The goal is to move the conversation about health from the hospital to the legislature, where the most important decisions about the health of a population are made. In recent years, a new and powerful determinant of health has emerged: climate change. The health production function must now account for the profound and multifaceted ways in which a changing climate affects our well-being. The direct health impacts of climate change are clear and growing. They include increased heat-related illnesses and deaths from more frequent and intense heat waves, and a rise in respiratory and cardiovascular diseases from a worsening of air quality. Indirect health impacts are even more widespread. Climate change can affect food security, as extreme weather events disrupt agricultural production. It can also lead to a rise in vector-borne diseases, such as Lyme disease, as the habitats of disease-carrying insects expand. The mental health consequences of climate change, from anxiety about the future to the trauma of extreme weather events, are also significant and growing. The policy response must be a co-benefit approach. This means designing policies that not only reduce greenhouse gas emissions but also have a direct, positive impact on public health. For example, a policy that promotes walking and cycling over driving reduces greenhouse gas emissions and also leads to a healthier, more physically active population. This reframes the climate debate from a cost to a benefit, providing a powerful new argument for climate action. The health sector also has a critical role to play. Hospitals and clinics are significant sources of greenhouse gas emissions, and they have a moral imperative to reduce their own carbon footprint. Public health professionals, in turn, have a duty to educate the public about the health impacts of climate change and to advocate for policies that protect the health of a population. This is a new and urgent challenge for the health production function. The final input into our modern health production function is data. The rise of big data and advanced analytics is fundamentally changing how we understand health. We now have the ability to collect and analyze massive datasets from a wide range of sources, including electronic health records, wearable devices, and social media. This allows us to move beyond simple correlations and to identify complex, nonlinear relationships between inputs and health outcomes. A particularly powerful tool is data linkage, which involves combining datasets from different sectors, such as health, education, and social services. This allows us to conduct a truly intersectoral analysis and to see how investments in one sector, like education, have a direct impact on health. This can provide the evidence base for a more holistic approach to health policy. However, the use of big data in health is not without its challenges. The privacy and security of personal health information are paramount. There is a real risk that this data could be used for discriminatory purposes. The data can also be biased. If we only collect data on certain populations, we may draw misleading conclusions about the health of the entire population. This is a critical ethical issue. The health production function provides a powerful framework for this new frontier of health economics. It tells us that to fully understand how we produce health, We need to look at all of the inputs, not just the ones that are easily measured. It is a call to action for health economists and data scientists to work together to develop a more sophisticated and equitable approach to health measurement and policy. As we look to the future, the health production function gives us a clear roadmap for health policy in Canada. The first and most important direction is a fundamental shift from a model of sick care to wellness care. This means moving from a reactive system that treats disease to a proactive system that prevents it. This will require a greater investment in public health, prevention, and the social determinants of health. This leads to the second key direction, intersectoral collaboration. To improve health outcomes, we must break down the silos between health policy and social policy. We must view investments in housing, education, and income support as health interventions. This requires a new way of thinking and a new set of political alliances. The third direction is to redouble our efforts to address the social gradient in health. This will require a commitment to reducing inequality and to building a society where everyone has a fair shot at a healthy life. This will involve bold, transformative policies that address the root causes of health disparities. Finally, the health production function also highlights the role of the citizen. We are not just passive recipients of healthcare, we are active participants in our own health. We have a role to play in advocating for a healthier society and in making healthy choices in our own lives. The health production function is not just an academic theory, it is a call to action. It is an invitation to think more broadly about what it means to be healthy and what it takes to build a healthier society. In conclusion, the health production function provides a powerful and comprehensive framework for understanding how we produce health. It forces us to move beyond a narrow focus on medical care and to consider a broad range of inputs, from a person's socio-economic status and education to the physical and social environments in which they live. It tells us that health is a product of our choices as a society, not just our choices as individuals. The output of our health production function is also more than just life years. It is about living with dignity, purpose, and well-being. The central message of this lecture is that to improve health outcomes, we must invest in the social determinants of health. We must recognize that social policy is health policy, and that a more equitable society is, by definition, a healthier one. Looking ahead, the health production function will continue to be a vital tool for policymakers, economists, and public health professionals. It will help us to navigate the new challenges of an aging population, the rise of chronic disease, and the profound health impacts of climate change. It will also help us to leverage the opportunities presented by new technologies and a growing understanding of genetics and epigenetics. The most important lesson is that health is a shared responsibility. It is the product of our collective actions, and it requires a commitment from all of us, policymakers, healthcare providers, and citizens, to build a healthier and more just society. Thank you.